Whenever you want to achieve something in life, always ask yourself every moment, how bad do you want it? If somebody drowns your head under the water, what do you want that moment? And how much do you want? Yes, you want that breath of air, and that is the only thing your mind and every cell of your body is thinking of, is wanting. So if your want for anything, if your craving for anything is like that craving of the breath of air, where your mind, your body, everything all the time thinks of only one thing, and that what you want to achieve. If you crave for something that much, you want it that bad, you definitely will get it. So ask yourself every morning, how bad do I want it? So with that, we start with another very important topic, and that is carcinoma of the larynx. Now we know that larynx has a very, very important function in respiration, in phonation, in swallowing, to prevent aspiration. So which means that if there is any carcinoma of this area, all these important functions of the larynx will be interfered with. That makes carcinoma of the larynx very, very important. And yes, this is not something which is uncommon. It is very, very common, because the most important etiological factor here is, the most important predisposing cause here is smoking. It is such a common thing. So since it is seen very commonly, since this is a very, very important area of the body, this is one part which is asked very commonly in your exams. So let us quickly see what a carcinoma of the larynx is, how it can affect, and what we do for it. So let us first start with knowing a few important facts about the carcinoma of the larynx. So yes, carcinoma of the larynx, if I ask you, so what is the most common type of carcinoma of the larynx? Yes, like any other place in ENT, the most common carcinoma everywhere in ENT is a squamous cell carcinoma, except for a few places that we have to know. For example, the skin which is exposed to sun, there, like the external nose, the skin of the pinna, there it is basal cell carcinoma. A carcinoma of the paranasal sinus which is exposed to hardwood. Do you remember? What is that most common? That is most common. It is adenocarcinoma. Otherwise, there are few exceptions that we have to remember. If you just remember those few exceptions, rest everywhere in ENT, the most common carcinoma is a squamous cell carcinoma. And yes, the most common predisposing cause is smoking. It is seen more common in males. So it is more common in males. Males is more common, males more than females, and the predisposing cause most common is smoking. This is most common, and we have other predisposing causes also, like alcohol. We have infection with human papilloma virus. This can predispose to carcinoma of the larynx. And again, we have irradiation to the neck. That again predisposes to carcinoma of the larynx. Now talking about the site and some important things about the carcinoma of the larynx. The most common site, what do you think, is of the most common carcinoma of the larynx is of which site? Yes, most common is of glottis. Glottis is, yes, the vocal cord, followed by supraglottis. And then last is subglottis. Right? Least lymphatic metastasis. Yes, we have done the lymphatic network so many times here, and we know that least is glottis. Yes, so least lymphatic metastasis is of glottis. And what do you think is the most lymphatic metastasis? Maximum lymphatic is of supraglottis. Yes, supraglottis has maximum lymphatics going to upper and middle deep cervical lymph nodes. Subglottis goes to lower deep cervical lymph node, and glottis literally has got no lymphatics. So maximum lymphatic metastasis is in supraglottis. That is to upper deep cervical and to middle deep cervical lymph node. The best prognosis will be of what? Yes, the one that has least lymphatic metastasis, that will also have the best prognosis. So best prognosis will be glottic. So that is nice, no? That most common is glottic, and that also has the best prognosis. Now, also glottis has the best prognosis because it is diagnosed very early. Why it is diagnosed very early? What do you think will be the presentation of glottic carcinoma? Glottic is at the level of vocal cord. So if there is any minor abnormality also on the level of the vocal cord, what happens? Yes, immediately the voice changes. So the earliest presentation of a glottic carcinoma is a change in voice. That makes the patient come to you very early. So the diagnosis is also early, and also the lymphatic metastasis is also not there. That is why glottic carcinoma has got the best prognosis. So earliest presentation is of glottic, and that is with hoarseness. So which carcinoma presents with hoarseness? Again, it is the glottic carcinoma. Whereas what do you think supraglottic carcinoma will present with? Supraglottis, we know it is epiglottis, yes, area epiglottic fold, we know all that area of the supraglottis. So what do you think if there is a carcinoma in that area? What will be the complaint? It is a relatively large area as compared to the glottis and subglottis. Yes, there, if it is an epiglottis that is involved, then maybe there will be dysphagia, difficulty in swallowing. Otherwise, supraglottic carcinomas remain silent for very long. And they initially many a times just present with lymph nodes in the neck. So, and subglottis patients will present. Yes, it is the only complete ring. So patient will present with stridor, but that will not be very early. Whereas in glottic carcinoma, little alteration of the surface of the vocal cord will lead to hoarseness. So yes, supraglottic carcinomas present with dysphagia, or they can also present with lymph node, and subglottic present with stridor. Yes, now what do you think? Bilateral lymphatic metastasis will be seen in bilateral. For the lymph nodes to go bilaterally, the structure usually has to be a midline structure. So which one is the midline structure? Yes, the epiglottis. So that is which carcinoma? Supraglottic. So bilateral lymphatic metastasis will be seen in supraglottic carcinoma. In epiglottis. Yes, and patients will present with dysphagia in which carcinoma? In supraglottic carcinoma. And pain in the ear can be because of involvement of which part of the larynx? Supraglottis, glottis or subglottis? We have seen the nerve supply of the larynx. All over it is vagus. Yes, so any part of the larynx carcinoma can lead to pain in the ear because of which nerve? Vagus. Does it also supply the ear? Vagus supplies the ear? Yes or no? Yes. Which branch of vagus? Auricular branch of vagus. Quickly tell me the name of auricular branch of vagus. Arnold's nerve. Yes. So we have pain in the ear because of vagus, and that is a referred pain, very, very commonly asked. So all these are important things which are asked in whenever a question is asked on carcinoma of the larynx. So now we know that the most common carcinoma of the larynx is a glottic carcinoma, and that will present with hoarseness of voice. Smoking is a predisposing cause and seen more commonly in male. So now let us combine this to form a question. So here we have a 50-year-old male who has been a chronic smoker who is presenting to you with hoarseness for more than 3 weeks now. Yes, so this is the presentation usually that is given to you. Elderly, male, smoker, presenting for hoarseness for more than 3 weeks. Any such patient should be investigated for carcinoma of the larynx. So here is a male smoker, and he is presenting with hoarseness for more than 3 weeks. Right? More than 3 weeks. So now this patient is sitting in front of you. He is having hoarseness. He is giving you the history of smoking. And what is in your mind is, yes, he's been having hoarseness for so long. Maybe a glottic carcinoma. How will you proceed going about investigating this patient and knowing whether actually he has this carcinoma of the larynx or not? Yes, the first thing is, what you will do is, you will examine his larynx. You will have a look at his larynx. If there is a tumor there, you will see it. Yes, you will see it. So what you will do now is, you will go for a laryngoscopy. You will go for a laryngeal endoscopy. So you will go for endoscopy. Yes, so you will go for endoscopy. Okay, this patient has come to you with this. So diagnosis will be by endoscopy. And on endoscopy, what you will do is, you are seeing, what are you seeing here? Yes, we are seeing there is a irregular ulceroproliferative mass that we are seeing on the vocal cord. Very much looks like carcinoma, but are we very sure just by having a look at the mass that this is carcinoma? No, we have to be very sure. How do we confirm? Yes, so we have to confirm by Yes, biopsy. We will take a biopsy. Yes, so if we have to take a biopsy from the true vocal cord area, how will we take the biopsy? Will we have to subject the patient under general anesthesia, or can we take this in the local anesthesia also? Yes, this at the level of vocal cord, just imagine. Can you do it in local anesthesia? No. So you can take it under general anesthesia. If it is supraglottic growth, maybe of epiglottis or high up in the supraglottis. For example, if you are seeing a growth like this, then this growth you can, yes, take the biopsy under local anesthesia. And if you want to give local anesthesia, which nerve will you anesthetize? And tell me, how will you anesthetize it? Which nerve? Supraglottis. Yes, internal laryngeal nerve. Where will you anesthetize it? Yes, very good. We will anesthetize it where it is entering into the larynx, just below the hyoid. At the thyrohyoid membrane where it is piercing, that is where we are going to anesthetize it. So yes, if it is a supraglottic growth, in supraglottic, you can take biopsy under LA. Okay, so now what we will do is we will take a biopsy. So we will take the biopsy under GA, or we will take it under LA in supraglottic. Right? And also what we will do when the patient is in front of you, also what you will do is you will examine the neck. Yes, why will you examine the neck? Yes, for lymph nodes. So you will examine the neck. So the first thing is you will do endoscopy. Second thing, you will go for confirming by biopsy. And along with this, you will examine the neck examination for lymph node. And second, can you know the extent of the tumor also by examination of the neck? Yes, if it has come out, you will see the broadening. This thyroid has got broadened. But usually patient has, as I told you, patient comes very early in glottic carcinomas. Yes, so that you will not find in most of the cases, though you can find if it has come out. But one thing you can note, and one thing you should note always whenever you are suspecting a carcinoma of the larynx, is for laryngeal crepitus. What is laryngeal crepitus? You push the larynx posteriorly and move it from side to side. What happens by this is, when you're pushing the larynx posteriorly, the cricoid will rub against the vertebrae, and that will produce a sound that is known as laryngeal crepitus, and this will be absent if the tumor has gone post-cricoid. Yes, so if the tumor has gone post-cricoid, so both the bony surfaces will not be able to come to meet each other, and crepitus will be absent. That is another thing that you need to note, laryngeal crepitus. You look for laryngeal crepitus. If it is absent, then that signifies that the carcinoma has got post-cricoid. So now you have got an idea by just examining the patient that yes, whether it has gone or whether it is still limited to the larynx. You did a biopsy examination. You examined everything from where all the tumor is going. Now you want to exactly know the things that you cannot see on endoscopy. Yes, whether the thyroid cartilage is invaded or not. Yes, whether the thyroid cartilage is invaded or not, that will make the tumor at advanced stage. How much is it going? Is it going to the paraglottic space, to the pre-epiglottic space? All that we cannot see on endoscopy. On endoscopy, we will be able to see the parts, the inlet, the cavity. Yes, so now we need to know the extent of the tumor so that we can stage the tumor. If it is an early stage, the management will be more conservative. It will be less of a radical management. If it is an advanced stage, the management will be more radical. So we first want to know what stage it is. Yes. So for that, to know the extent of the tumor, we will have to go for some radiological investigation. Which one will you choose? CT or MRI? We have to do both here, both CT as well as MRI. Why CT and MRI? Yes, we will have to next go for CT plus MRI. Yes, CT will show the bone involvement, and MRI is for cartilage invasion. Always remember, whenever we have to see the cartilage invasion, we go for MRI. Cartilage, and this has been a repeated question in your exam. Cartilage, for seeing the cartilage invasion in carcinoma of the larynx, which is the investigation of choice? In fact, when you must have read ortho, you must have seen that there also that for cartilage we always get MRI done, and that is one thing I never used to understand when I was in my MBBS. Sometimes if there is pain in any joint or anywhere in the hand, anywhere here on the wrist, elbow, anywhere, we used to go to show to the orthopedician, and they used to tell us get an MRI done. And I used to wonder that the problem is in the bone. Why they always ask for MRI? They should be asking for CT, right? Yes, so it is only when then I thought that what is the reason. We came to know that time that yes, we asked them, they told that they do not want to see the bone. What they want to see is the articulating cartilage. So whenever they want to see the cartilage, what is the investigation of choice? It is MRI. So here also it is MRI. So now you have investigated the patient and now you will stage this patient. Okay, so now let us see how much extent is what stage of the tumor. Again, this is one staging. In ENT, that is very, very important for us and we should know that. So what is T1? This is the TNM classification, the tumor extent, the neck node and the metastasis classification. So what is T1? T1 is when the tumor is confined only to one site. One site means, what is this site? This is the supraglottis, this is glottis, this is subglottis, right? So if it is localized to only one side, if it is only localized to glottis or only to the subglottis or in the supraglottis, we know supraglottis is a large area. It is not like glottis and subglottis, yes? So in the supraglottis, if there is involvement of only one subsite, in the supraglottis, we have so many subsites. We have epiglottis, we have AE fold, we have false vocal cord. So if there is involvement of only one subsite in the supraglottis, one subsite, then we call it as T1. So if we want to just simply easily remember it, what we can remember is that T1 is whenever there is involvement of one named structure. Epiglottis. Only epiglottis is involved, T1. Only glottis is involved, T1. Only subglottis is involved, T1. If epiglottis as well as false vocal cord involved, yes, then that is not T1. Okay, so if there is only one named structure that is involved, that is T1. So just remember it like that. So now let us see how we stage the carcinoma of the larynx. And yes, this is one staging which is asked very, very commonly in your exam. So this staging we need to know very thoroughly. Now this is the TNM classification. The T is the tumor extent, N is the neck node and M is the metastasis. Yes. So let us see what is T. T is the tumor extent. Now T1. So we can remember T1 is, it is 1. So it is only one subsite. Okay. It is only one site or one subsite involved. One site or one subsite involved. Now, what is the meaning of site and subsite in the larynx? Yes. Now, we know that larynx has three sites, supraglottis, it has glottis and it has subglottis, right? And supraglottis is again divided into many subsites. We have the epiglottis, we have ariepiglottic fold, we have false vocal cord. Yes, so what is T1? T1 is when only one site is involved. For example, only glottis is involved or only subglottis is involved. Now, in the supraglottis, since we have so many subsites, even one subsite, if it is involved, that is T1. Which means what we can remember, for remembering we can remember as whenever there is one named structure involved, one named structure. For example, only epiglottis, then that is T1. Only glottis, that is T1. Only subglottis, that is T1, right? Epiglottis as well as false vocal cord, will that be T1? No, it is involving the supraglottis only, but it is not only one subsite, right? So just remember it. For remembering it like that, T1 is only one named structure. Okay, remember it like that. T1 is only one named structure. Either epiglottis or only false vocal cord or only glottis or only subglottis. So one named structure. Okay, so this is just for you to remember. Don't write this when you write the classification of the carcinoma of the larynx. Okay, now in the true vocal cord, that is in the glottis, at the level of the glottis, the T1 is further divided into T1A and T1B. What is T1A? T1A means that there is only involvement of one vocal cord and T1B means involvement of both the vocal cords. Is that clear? So this is only for glottic, T1A and T1B. It is not for supraglottic or not for subglottic. It is only for glottic. T1A is only one vocal cord involved. And T1B is both vocal cords involved, right? Both vocal cords involved, and this is only for glottic. Right now, also always remember that T1 is whether it is involvement of supraglottic, any one structure, epiglottis, or it is involvement of glottis or subglottis, whether it is T1A, only one vocal cord involved, or both the vocal cords involved, both the vocal cords are mobile here. Is that clear? The vocal cords are mobile. That is a catchy term. Okay, so it only one side or one subside. One side and one subside with both vocal cords mobile. Is that clear? So whenever in any question, it is whatever area is involved, it is given that both vocal cords mobile. We know that it can be T1. Is that clear? Okay. Now what is T2? T2 means that two sides are involved and they are adjacent, or two subsides are involved of the supraglottis but they are adjacent. For example, if from the glottis it goes to supraglottis. What is adjacent to glottis? Supraglottis. Or adjacent to glottis is subglottis. Okay. Now if from supraglottis it comes to glottis, just to adjacent, it is not going from supraglottis to subglottis. It is going from supraglottis to the adjacent structure. What is that? Glottis. From glottis it is going either to supraglottis or to subglottis. So when two structures are involved and both of them are adjacent, epiglottis involved, along with that area epiglottic fold also involved, they are adjacent. So whenever two adjacent sides or adjacent subsides are involved, that is what is T2. T2 means two adjacent. Obviously, if it goes from one place to the next, the ones that is nearest to it will only be involved, right? So, two adjacent sides or subsides involved, and here with now here T2A is with both vocal cord perfectly mobile. Okay, and T2B is that the vocal cords are mobile but they are not fully mobile like a normal vocal cord. There is some impairment of the mobility. Okay, so impaired mobility, but still it is mobile, it is not fixed. Okay, so impaired mobility. Is that clear? So if it is given in any carcinoma, that carcinoma of the larynx with fixed vocal cord, can it be a T1 or T2? No. If it is carcinoma of the larynx with mobile vocal cord, it can be either T1 or it can be T2. Now what is T3? T3 is either when the vocal cords have become fixed. Okay, so if any carcinoma has been mentioned with fixed vocal cord, immediately know it is a T3. It is a T3 extent. Now, why this is important? This is a very, very important catchy term that you have to remember and you have to look for in the questions. And why is it important to know that it has become T3 now? Because the management of the carcinoma of T1 and T2, that is same, whereas from T3 it changes. So we have to know that when a tumor of the larynx becomes a T3. So first is when the vocal cord becomes fixed, and second is when the carcinoma goes outside but it is very near. One is it goes to the pre-epiglottic space. From the epiglottis, we know we have multiple foramina here. From here, it can very easily go into the pre-epiglottic space, yes. And from pre-epiglottic, it can go to the paraglottic also. So, it goes to the paraglottic space. It goes anteriorly to involve only the very inner cortex of thyroid. Okay, please note this. It is only inner cortex. It is not the complete thyroid cortex. Only a very small part. That's the inner cortex of the thyroid. Or it goes posteriorly. When it goes to the post-cricoid area. So all these points are important for you to know because that will change the stage of the tumor, and not only the stage of the tumor, it will also change the management that you will undergo the patient. You will subject the patient to. So here T3 is when the vocal cord is fixed. Second, when the tumor has extended to pre-epiglottic space. Pre-epiglottic space, it has gone to paraglottic space. Okay, so it is just anteriorly, side, and it is going anteriorly, it is going to the side, it is going posteriorly. Okay, it has gone to the post-cricoid area. or it has involved the inner cortex of thyroid. Right? Is that clear? And what is T4? T4 is again divided into A and B. What is A is? A is when the tumor has gone out of the larynx, but it is locally. For example, if the tumor goes out, where can it go? Okay. Now, if you remember it with the picture, then it is more likely that you will remember it. If you just ratify, you will not remember. So, if it has gone out of the larynx, means where has it gone? If it has gone out from here, from the anterior part, where will it go? Yes, it will completely involve the thyroid cartilage. From there it will go out. What do we have here? We have the thyroid gland. Here we have the strap muscles then. Yes, so involvement of the thyroid cartilage, involvement of the thyroid gland, of the strap muscles. Yes, if it goes superiorly from the supraglottis, where will it go? It will go to the muscles of the tongue. If it goes inferiorly, it will go to the trachea. If it goes posteriorly, it will go into the esophagus. Yes, so all this is T4A. It has gone out, but still it is local. It has gone out, but locally. That is T4A. So T4A is when it has gone to the thyroid cartilage, complete thyroid cartilage invasion has occurred. The thyroid gland, so just remember it sequentially, anterior, posterior, superior. Okay, then let me also write it sequentially for you. Okay, so if it has gone anteriorly to thyroid cartilage, thyroid gland. If it has gone to strap muscles, okay, when it goes superiorly, where will it go? To the tongue muscles. If it goes inferiorly, where will it go? If it goes inferiorly, it will go into the, yes, tell me, trachea. If it goes posteriorly, it will go into the esophagus. Right? So that is what is T4A. And what is T4B? T4B is when it has gone out, but it has gone to such areas where the tumor will become inoperable. You cannot operate this tumor. So which means that you can just go for a palliative management for this patient. The tumor has gone out to such an area which makes the tumor unresectable. For example, if it has gone to the prevertebral area, if it has gone to the mediastinum, if it has gone to the carotid sheath, to the base of skull, so all that will make the tumor unresectable. So that is T4B. So T4B. What is T4B? T4B is tumor has become unresectable. Because of its extension to prevertebral space. Yes, many a times it is asked that carcinoma of the larynx, some presentation is given and it is given that it has gone to the prevertebral space. It is involving the vertebrae. So prevertebral space. It has gone to involve the carotid sheath. It has involved the mediastinum. Right? So all that makes the tumor inoperable. So that is what is T4. So is that very clear for you? Yes. So now quickly tell me, a patient of carcinoma of the larynx involving the right and the left true vocal cord with bilateral vocal cord mobile. Bilateral mobile vocal cord. Which stage can it be? Can it be a T3? Yes or no? No, it can be either T1 or T2. Is that clear? T1 or T2. Okay, carcinoma of the larynx involving the epiglottis with bilateral mobile vocal cord. Again, it can be either T1 or T2. Now, always remember that whenever it is asked, what we need to know is whether it is T1 or T2, or what more important we need to know is when it is T3, because that will change the management, right? Carcinoma of the larynx involving whatever area, epiglottis, false vocal cord, true vocal cord, with fixed vocal cord. Now it is T3. Okay. Now, carcinoma of the larynx with perichondritis of the thyroid cartilage. Yes, involving the complete thyroid cartilage. Now it is T4A, involving the prevertebral space. Now it is T4B, involving the carotid sheath. That is T4B, which means what we have to look for is vocal cord fixed. Vocal cord fixed, which stage? T3. Vocal cord mobile, which stage? T2 or T1. Okay. When it is involving the cartilage through and through, the thyroid cartilage, that is T4. Yes, it is going to the prevertebral space, that is T4B. Is that very clear for you now? Okay, so now what we did is, this patient came to us, an elderly smoker who had hoarseness for around 3 weeks, and we investigated the patient, we examined the neck of the patient, we examined the larynx by laryngoscopy, and there was a growth. We took the biopsy. It came out to be a squamous cell carcinoma, and we took up the patient for a CT scan. Will we get the MRI done? Yes, MRI will show what? Will show cartilage invasion. So now, according to the extent of the tumor, we have graded the patient as either it is T1, whether it is T2. Now, if there is a tumor that you are seeing of the epiglottis, which is going into the pre-epiglottic space, then it is what stage? It is T3. Whether the vocal cord is not mentioned, whether it is mobile or fixed, but it is of the pre-epiglottic space, then it is T3. Paraglottic space, again T3. Vocal cord fixed, again T3. If it is going to the postercoid area, again T3. Yes. So now we have seen all this pre-epiglottic, paraglottic, all that by CT, and cartilage invasion we have seen by MRI. Yes. So if there is complete thyroid cartilage invasion, does that change your stage? Yes, that will make the stage T4. Complete thyroid cartilage invasion is T4. Have you understood till here? That okay, so we got the investigations done, and now according to what all we saw was involved, we graded the tumor as T1, T2, T3 and T4. Right? Now, what is transglottic tumor? Sometimes it is mentioned transglottic tumor. The patient has a transglottic. What's the meaning of transglottic? Transglottic means it is involving all the three parts of the larynx, all the three sides of the larynx. It is involving the supraglottis, the glottis, subglottis. So it has gone from the glottis to the supraglottis, from anywhere. But now, when you're examining, you are seeing all the three sides are involved, and or any tumor which is in the paraglottic space. We know paraglottic space lies lateral to the complete larynx. So if any tumor has gone in the paraglottic space, that also we call as transglottic, because this would involve any part of the larynx. So transglottic tumor is when the tumor involves all the three sides or paraglottic space. So tumors which are from the ventricle, they can go out into the paraglottic space from the ventricle. So if they are involving all the three sides, that is transglottic tumor. So now we have staged the T, that is the tumor extent. Now what next we want to stage is the neck node. Yes. So how do we stage the node? So when there is no neck node, that is N0, no neck node. That is N0. Now what is N1? N1 is a single ipsilateral on the same side of the tumor lymph node, which is less than or equal to 3 centimeters. So what is important is it has to be a single. Okay, single. It has to be ipsilateral on the same side of the tumor. Ipsilateral tumor, and it is less than or equal to 3 centimeters. Now what is N2? N2 is when the tumor is more than 3 centimeters and it is up till 6 centimeters. Okay, so it is 3 to 6 centimeters in size. The N2 can be further divided into N2A, N2B and N2C. N2A is when it is single, when it is ipsilateral, and it is from 3 to 6 centimeters, right? Now N2B is when it is multiple ipsilateral, less than 6 centimeters. Okay, so see here what it means, that if it is a carcinoma that is of the right vocal cord or of the right supraglottis, going to the supraglottis, or it is involving the right side of the larynx, and in this patient there is a lymph node in the right side of the neck, and that lymph node, if it is a single lymph node which is 3 to 6 centimeters, we call it as N2A. But if there are multiple, you are seeing 5, 6 or 3, 4 lymph nodes, multiple, even very small, 1 centimeter or it is 2 centimeters, but there are multiple, then the stage increases, which means that the size, more than the size, what is the indicator of that it is an advanced stage is the character of the tumor to spread. So even if it is a small lymph node, but if there are multiple on one side, multiple small lymph nodes on one side, that is a more advanced stage than a single big lymph node on one side. Yes, if it is a single big lymph node on one side, that indicates that okay, it is there, a tumor is there, but still it is localized. It is not having the metastatic potential of spreading very fast. Whereas if there is a small lymph node and multiple of them, what does that indicate? It indicates that the tumor has just gone to one lymph node and the spreading potential, the metastatic potential of the lymph node of the tumor is so much that it has gone into one lymph node. That lymph node has not even grown, it has gone to other lymph nodes also. Yes. So if it is multiple lymph nodes, whatever size but less than 6 centimeters, but on same side, that is what is N2B. And what is N2C? N2C is either multiple or single, but contralateral. Okay, bilateral or contralateral. So if there is a carcinoma of the right side of the larynx and there is a lymph node on the left side also, or there is a lymph node only on the left side, usually it will be both. Yes, so on the right also, and now it has gone on the left side also, it indicates that there is a more spreading potential of the tumor. So even if it is a small lymph node on the left side, maybe only 1 centimeters, here also only 1 centimeters, okay, but that stage is an advanced stage of the lymph node. So if it is a single or a multiple, but if it is bilateral or it is contralateral lymph node less than 6 centimeters. Anything less than 6 centimeters can be 1, 2, it can be 4, 5, 6. That is what is N2C. So N2C is multiple or single but bilateral or contralateral lymph nodes. Now N3 is anything which is more than 6 centimeters. Okay, N3A is when it is a single ipsilateral more than 6 centimeters. And what is N3B then? N3B is when there is any size lymph node, but there is an extranodal extension, which means if this is the lymph node, okay, it is going out of the node. It is going out of the node. So that is an extranodal extension. That you can find out if it is adhered to the skin, you know it has gone out, or by histopathology you can find out that there is an extranodal extension. So which means that all this above that we did from N1 to N3A is negative extranodal extension. Extranodal extension is known as ENE. So this is ENE negative. Is that clear? So if there is any lymph node even 1 centimeters in size, but if there is a extranodal extension on histopathology, then that will immediately, or you are seeing it is maybe 3 centimeters, but it is adherent to the skin. So extranodal extension is there. That changes the stage of the tumor to a 3B, N3B. So rest all is extranodal extension negative. So is that very clear? We graded the tumor's extent, the size, we graded the lymph node. So you have graded the lymph node, but which lymph nodes did you examine? Which are the lymph nodes which will be enlarged if there is a carcinoma of the larynx? Yes, so if there is a carcinoma of the larynx goes to which lymph nodes? Yes, we have which lymph nodes? So here we have the submental and the submandibular, that is one, okay, that we are not interested here. What we are interested here is the ones which drain the larynx. Which are these? So here we have the internal jugular vein divided into 3 parts: upper 1/3, middle 1/3 and lower 1/3. Yes, so this is the level 2 lymph node. This is the level 2 lymph node, this is level 3 and this is level 4, right? Now the 2 is in between the digastric and the jugular, so it is also known as jugulodigastric, or it is also known as upper deep cervical. This is middle deep cervical. 3 is middle deep cervical, or it is in between the omohyoid and the jugular. So it is known as jugulo-omohyoid, or it is level 3, and this is level 4. So yes, the carcinoma of the larynx goes to 2, 3, 4, 2, 3, and 4, and along with this is also goes to the anterior group of lymph nodes. Which are the anterior group? Anterior group are the precricoid and the pretracheal. Okay, that is level 6. Level 6, that is the pretracheal, precricoid, or they are also known as Delphian lymph nodes. Delphian lymph nodes, right? So now which part goes to which lymph node? Supraglottis drains into upper and middle deep cervical, that is 2 and 3, and subglottis drains into will drain into these lymph nodes. So these are the lymph nodes that you are going to examine to look for any enlargement of lymph nodes to stage for the node. So now we know the tumor extent, we know the node that are involved, and now let us stage it. Yes. So the stages of the carcinoma of the larynx is, again, it is 4 stages like other tumors. Stage 1, very simple to remember, T1, N0, M0, right? This is very simple. Stage 1 is T1, N0, M0. I think all the tumors, it follows the same stage. T2 is what? T2, N0, M0. T3 is what? T3, N0, M0. Yes. And also T3 is T1, T2, T3 with neck node with N1. I will write it down. Wait. Okay. So T1 is T1, N0, M0. T2 is T2, N0, M0. T3 is T3, N0, M0. Or it is T1, T2, T3, T1, T2, T3 with N1, which means that if there is a node in the neck, it is straight away which stage? It is stage 3. Yes. So that is, and what is stage 4? Stage 4 is divided into 4A, 4B and 4C. 4A is T4, N0, M0, or it is T4, N1, M0, or T1 to T4, N2, M0. So it is one step ahead of this and one step ahead of this. Is that clear? So now T1, T2, T3, T4 with N2. So if there is a N2, that is a T4 stage 4A, and stage 4B is T4B with any N and no metastasis, M0. And if there is a metastasis, that becomes stage 4C. So now we have staged the carcinoma of the larynx also. Now let us see how we will manage a carcinoma of the larynx. Yes. Now, whenever we are thinking of managing the carcinoma of the larynx, our aim of management is to preserve the larynx. Yes, we can definitely remove the larynx with the tumor. We can go for a total laryngectomy and we can remove the whole tumor along with the larynx, yes, and cure the patient completely of the tumor. But along with that, we are also removing the larynx that has got such an important function. Yes, so whenever we manage the carcinoma, our aim of management is to conserve the larynx, to preserve the larynx. So with that in our mind, let us see what the management of the carcinoma of the larynx is. So for early stages, T1 and T2, okay. Now T1, you tell me what is T1? Yes, first tell me what is T1. T1 is only one side or one subside. Okay. So then here we have for T1 and T2. Just remember, for T1 and T2, we have two options. TLM, that is resection of the tumor with the help of laser. Okay, just how we remove the vocal polyps, we remove the nodules, granulomas, all that also we excise. No? So this also what we are doing is we are excising it. That is what is TLM. What is the full form of TLM? TLM means transoral laser microsurgery. Yes, It is simple to remember what is transoral. You are going transorally to operate on the larynx with the help of laser. What is the laser that we use here? Carbon dioxide laser. Microsurgery, because we do it with the help of microscope so that we can visualize the margins very clearly. Everything of the larynx, when we operate microscopically. So we have two options for early stages. For early stages, we either go for TLM or we go for radiotherapy. Both are going to preserve the larynx. Yes, TLM or radiotherapy, right? Now, how we decide whether TLM or whether radiotherapy? So let us see that. Okay, so if it is a T1A. What is T1A? T1A is when it is of the glottis only of one vocal cord, right? So if it is only of one vocal cord and it is involving only mid cord, right? This is very much like how tumor, how polyps appear, how benign conditions of the vocal cord can also appear. And what do? We just excise it. So in these patients, we do not give them the option of radiotherapy. We just excise it. Why? Because that is not exposing the patient to the side effects that radiation will give him. And this is what we do for most of the benign conditions also, that we excise that mass. So this is not going to give lot of damage to the vocal cord which is going to affect the voice, not that much. Yes, so why not just excise it? Why expose the patient to radiotherapy? So if it is just T1A, where the only part that is involved is the mid cord, where we can see very clearly all the margins, then just go for TLM. Don't give the option of radiotherapy to the patient then. So here we will go only for TLM, right? And T1B, when both the vocal cords are involved, then you can give the choice to the patient, either TLM or radiotherapy. Both have equal prognosis. Okay, so whatever is there in the choice, either TLM or radiotherapy, only one will be there. Okay, either TLM will be there or radiotherapy will be there. You can mark either, whatever is given, as the answer. T2A. What is T2? T2 is when it has gone to the adjacent site or adjacent subsite. So now again you have to go for either TLM or radiotherapy, right? Both are equal prognosis. Now, when the vocal cords have become impaired, what's the meaning of impaired? The vocal cord mobility has become impaired means that there is a little deeper invasion of the tumor, which maybe if you just excise by TLM, maybe there is a deeper invasion which you're not able to visualize. So in that case, the preferred option is a radiotherapy. Now, just please always remember, try to understand what you're doing. So if you are knowing that what is this tumor, this is a tumor which is called impaired mobility. So then you know that why you do not want to go for a TLM there, why you prefer giving a radiotherapy. Because a deeper invasion, maybe you will miss excising on TLM because you will not know how deep it has gone. So then you prefer going for radiotherapy. So which means that what you have to know is whenever it is a T1 or a T2, the options that we have is either TLM or radiotherapy. If it is a localized small tumor on one vocal cord, TLM will be preferred. If it is an impaired vocal cord mobility, yes, then radiotherapy will be preferred. But in both the situations, what will be mentioned in the question? Yes, it will be mentioned is that the tumor is there and the vocal cords, yes, vocal cords are mobile. That tells you that it is T1 or T2, or maybe it is impaired, but it is not fixed, right? Now, if it is fixed means it is T3. Tell me more about T3. When else can a carcinoma of the larynx become T3? Yes, one, the vocal cord is fixed. Second, when it has gone to preepiglottic. When it has gone to, tell me, yes, you have to tell me, paraglottic. Yes, inner cortex of thyroid, postricoid. Then in all these stages, now what you will go for is a concurrent chemoradiation. Here also we are not doing total laryngectomy. Are you seeing how much we are trying to preserve the larynx? We are going for concurrent chemoradiation. Concurrent chemoradiation means you are giving chemotherapy as well as radiotherapy at the same time. You are giving radiotherapy, then few chemotherapy, then radiotherapy, then chemotherapy. And the chemotherapy that we use here is cisplatin. Chemotherapeutic agent that we use here is cisplatin. We use carboplatin, and we use 5-fluorouracil, right? Now, T4A. What is T4A? When it is now locally, it is gone out of the larynx. Though locally, but it has gone completely out. In that case, we will not be able to preserve the larynx. Yes. So in that case, that is the only place now where we are going for a total laryngectomy. So we are going for total laryngectomy followed by radiotherapy. So we are giving a combined modality treatment here of total laryngectomy followed by radiotherapy in T4A, right? And also always remember, whenever there is extensive cartilage involvement anyway makes a tumor T4, but whenever there is extensive cartilage involvement, in cartilage involvement, we never prefer giving radiotherapy because that leads to radio necrosis of the cartilage. So that is why in that case, we always go for total laryngectomy. Yes. And T4B, what is B? B, it is when it is gone, tumor is unresectable. So unresectable, definitely we are not going to go for any surgery. What we are going to give here is palliative management. Palliative management can be for pain, it can be for yes, radiotherapy can also be given here to reduce the bulk of the tumor, but it is not a curative management that we are giving to the patient. This is palliative management. Now, when we are doing TLM for a glottic carcinoma, what is TLM? Transoral laser microsurgery. We are cutting the tumor. Yes. So when we are doing a TLM for a glottic carcinoma, means of the vocal cord. So there are chordectomy, we are doing chordectomy, we are removing a part of the true vocal cord. So this chordectomy is 5 types. Yes, and we need to know what are these 5 types. So that is simple. We know the cut section, we know the anatomy very nicely. We know the cut section of the true vocal cord. Here we have the epithelial lining. This is the epithelial lining. Yes, can you tell me what is the epithelial lining? Yes, that is the stratified squamous epithelium. Then below that we have the lamina propria. Yes, then we have the collagen elastin fibers forming the vocal ligament. Yes, and then lateral to the vocal cord we have the muscles. Yes, we have the muscles of the vocal cord. So now if we cut from here, okay, below the epithelium, this is type 1. What have we done? We have done subepithelial chordectomy. Subepithelial chordectomy. Now, what will be next when we have cut from even more deeper? So, we have cut up to the ligament also, right? That is a subligamental. What will be type 3? Type 3 will be when we have removed a part of the muscle also. So, that is transmuscular. Type 4 is when you have removed the whole of the vocal cord. Whole of the vocal cord you have removed. So that is total chordectomy. And type 5 is extended. Extended means along with one vocal cord, maybe you are removing some part of the other vocal cord also. So it is extended, or you are removing some part of the subglottis also. So all that is extended. So in TLM, this is, do you remember, this is the same as when we were doing lateralization of the vocal cord also. We can lateralize it little by just a subepithelial chordectomy, little more by subligamental, little more by subtransmuscular, or complete by chordectomy, total chordectomy. And in TLM, which laser do we use? Yes, I have already told you this. We use the carbon dioxide laser. So now we examined the patient, we saw the extent of the tumor, we saw the neck node involvement, and we staged the patient, and accordingly we managed the patient. Have you understood that? Okay, so now before we proceed, you are now going to tell me. Now this is the patient who presented with hoarseness of voice, difficulty in swallowing. Now when we examined, what we saw is that this is what is given in the question. Okay, so listen to the question properly. What you saw is that there is a tumor which on biopsy showed squamous cell carcinoma, and this tumor is involving the supraglottis as well as the glottis with bilateral mobile vocal cord. Can you make out of all the long history what was the most important part? Bilateral mobile vocal cord, right? What will be the management of this patient? Bilateral mobile vocal cord management. Either TLM or radiotherapy, right? Either TLM or radiotherapy. Whatever is given in the choice, you can mark it. Okay. Now, again, let me change only one word in the question with fixed vocal cord. Now, will your management change? Yes, management will change too. Now, concurrent chemoradiation. Okay, now let me add something more. There is perichondritis of the thyroid cartilage. Now, it will become a total laryngectomy followed by radiotherapy. Is that very clear? Okay, now in this patient. Yes, now tell me, this is carcinoma of which area? This is carcinoma of, yes, this, of one vocal cord, and it is involving the midcord. Tell me the management of this patient. Do you want something more for me to tell you? Okay, bilateral vocal cord mobile. Bilateral vocal cord mobile. Now, yes, now you will go for TLM. If I tell you that the vocal cord is fixed, now it becomes concurrent chemoradiation. Something else I will add. It is gone to the thyroid cartilage. Then now it has become, now management will become total laryngectomy followed by radiotherapy. Okay, now here. This is a tumor of the larynx of the involving one vocal cord. You can see all the extent of the tumor with bilateral mobile vocal cord. Now management, bilateral mobile vocal cord. You see the TLM or radiotherapy. With fixed vocal cord, now it will be concurrent chemoradiation. Okay, now this patient, tell me this. Yes, you are seeing a tumor in the supraglottis. Yes, so supraglottic tumor involving the epiglottis, involving the false vocal cord with bilateral mobile vocal cord. Yes, TLM or radiotherapy. If it is given impaired mobility of the vocal cord, then you will prefer radiotherapy. If it is given fixed vocal cord. So all that we are seeing is whether the vocal cord is mobile, whether it is impaired, whether it is fixed vocal cord. Now, concurrent chemoradiation. Thyroid perichondritis. Now, total laryngectomy followed by radiotherapy. Okay, this is a tumor of the epiglottis going to the pre-epiglottic space. Pre-epiglottic space is involved. Now, which stage is it? Pre-epiglottic space? Yes, it is T3. Paraglottic space? T3. Postcricoid? T3. Inner cortex of thyroid? T3. Now, any of these is mentioned. Now, the management will be concurrent chemoradiation. Is that absolutely clear? Yes. So, also one thing that you need to note and remember, this will never be asked from you. Okay, but still, I am telling you this for sake of completion of the carcinoma of the larynx. Why? Because subglottic carcinomas are very rare. This is the part that will never be asked from you. Okay, but still, subglottic, if there is a carcinoma of the subglottis, we cannot excise that area by a laser. We have cricoid cartilage all around. And what do we have in the subglottis? A thin layer of mucosa, and then we have the cricoid cartilage, right? So, here we have only two options. No option of TLM. Early stage, give radiotherapy. Late stage, total laryngectomy followed by radiotherapy. Is that clear? Yes. So, this is what we need to know about the carcinoma of the larynx, staging as well as management. Now, we manage the tumor. What about the neck? What about the lymph nodes? Can we leave it? If we just remove the tumor and leave behind the nodes, lymph nodes, immediately it will spread. Yes, it will metastasize. So, we want to remove the neck nodes also. So, whenever there is any neck node, we have to go for the management of neck also. And here, the management of the neck will be with the help of a neck dissection. This neck dissection can be a radical or a modified radical neck dissection. Is that clear? So, if there is any lymph node present, then you have to go for neck management also. And this neck management, if you are operating the larynx, then you have to go for a neck dissection. If you are going for radiotherapy to the larynx, concurrent chemoradiation, then you have to give chemoradiation to the lymph nodes also. So, if the primary is being managed by radiation, manage the lymph nodes by radiation. If the primary is being managed by surgery, then go for a neck dissection. And the neck dissection has to be either a radical or a modified radical neck dissection if there is any lymph node. So, what is the difference between radical and what is the difference between modified radical neck dissection? Now, in the neck, we have seen that there are 5 groups of lymph nodes. Yes, the 1, 2, 3, 4 we already saw. 6 also we saw. What was 5? 5 is the posterior group. Yes, posterior group in between the sternocleidomastoid and the trapezius. That is the posterior group. So, lymph nodes that are removed in radical is 1 to 5. All the 5 groups are removed. Now, there are certain non-lymphatic structures that also we remove in radical. One is nerve, one is vein, and one is muscle. What is the nerve? Nerve is the spinal accessory. Vein is the internal jugular vein, and muscle is the sternocleidomastoid muscle. Now, along with that, if required, in radical can also be removed the parotid gland, the submandibular gland, or the omohyoid muscle. Now, what is modified radical? Modified radical is that yes, we remove the lymph node group 1 to 5, but we are preserving certain structures. So, modified radical neck dissection can be either 1, it can be 2, or it can be 3. 1 is when we preserve one structure. If I ask you that preserve only one structure out of the nerve, the vessel and the muscle, which do you think is the most important that needs preservation? Yes, the nerve. So, here you preserve the nerve. Preserve two things. Which two things will you preserve? Yes, the nerve plus vein, IJV. 3, you preserve all the 3. Preserve nerve plus IJV plus muscle plus sternocleidomastoid muscle. So, the type 3 is what is known as functional neck dissection. So, functional neck dissection is modified radical neck dissection type 3. Type 3, where we are removing only lymph nodes 1 to 5. Okay, now just tell me that larynx, does it ever go to 1? Submental, submandibular. Does it ever go to 5? No, it doesn't. Yes, so if there is a carcinoma of the larynx that we are treating, for example, a supraglottic carcinoma. In supraglottic carcinoma, right now, the neck does not have any lymph node, but we know that supraglottic carcinomas have a high propensity of lymph node metastasis. So maybe right now when we are examining the patient, we are not able to find out, but there is some occult lymph node metastasis. So in supraglottic tumors, whenever we are operating supraglottic carcinoma, even if there is no neck node, we always need to go for a neck dissection because the chances of occult metastasis is very high there. So if there is no neck node, but because the chances are high there, we are removing the lymph nodes, then we need not remove the 1 also, the 5 also. All we need to remove is the lymph nodes or to which the supraglottis or the larynx drain into. So, this is which lymph node? This is 2, 3 and 4. So, this 2, 3 and 4 is what is known as lateral neck dissection. Lateral neck dissection is removing 2, 3, 4. 2, 3, 4 is lateral neck dissection, and we need to remove the Delphian lymph node, that is known as anterior neck dissection. So, this is a question that is asked in your exam, that in carcinoma and tumors of the larynx, what selective neck dissection do we do, or which group of lymph nodes do we remove? So, when we are being selective in the lymph nodes also, we are not removing all 1 to 5 group that we remove in modified radical neck dissection. That is what is known as selective neck dissection. So, selective neck dissection is when we remove the lateral as well as anterior group, and this we do in supraglottic carcinomas, which right now are N0. They are N0, but we know that there are high chances that there might be a occult metastasis. So, this patient who came to us, we managed the tumor also by either a TLM or radiotherapy or total laryngectomy followed by radiotherapy. Depending upon the extent of the tumor, we manage the neck also. Now, this carcinoma of the larynx, as I told you, is a very, very commonly asked topic, and that is why I am just going very slow, and I am just making sure that you have understood each and every part before we proceed. Yes, if I just tell you this is 1, 2, 3, 4 and this is the management for 1, 2, 3, 4, that is done, but I'm sure you will not remember it. How many tumors can you just stratify? Yes, so try to understand and try to remember. So is it absolutely clear till here that how you manage the tumor, how you manage the neck? Now suppose you send this patient back. You have done a TLM for the patient, or you have done a radiotherapy for the patient, and you have sent the patient back, and now the patient comes back to you with recurrence. Now, when the patient comes back to you with recurrence of the tumor, if you have given radiotherapy earlier, for example, for stage 1 and stage 2, where you could go either for TLM or for radiotherapy, or in stage 3, where the management is concurrent chemoradiation, what you chose was radiotherapy. So, you have given the patient radiotherapy for T1 and T2, or you have given radiotherapy as a part of concurrent chemoradiation when the patient was T3. So, you have already given radiotherapy to this patient once. Patient has come back to you again with a recurrence. Do you know that if radiotherapy has been given to one part once, it cannot be repeated again? Yes, it cannot be repeated again. So now the patient has come to you again with a tumor of the larynx and radiotherapy is out of the choice. What have you left with? Are you left with? Can you go for TLM if the stage is early? Yes, TLM cannot be done. Why? Because in TLM, we are doing laser excision. We are visualizing what is the tumor, where is the tumor, and we are excising it. Yes. So whenever radiotherapy is given, that area is fibrous. There is fibrosis of that area, so you cannot make out the margins. So TLM is also out and radiotherapy is also out. So what is the option that we are left with now? Only total laryngectomy. Yes. So if the patient has come with recurrence and if you have given primarily radiotherapy to the patient, then the only option that you have is surgical, that is total laryngectomy. But remember this, if it is a early stage, that is a stage 1 and stage 2, then what we can do here is we can go for surgery where we do not remove the complete larynx. We do not go for a total laryngectomy. We go for a partial laryngectomy. That is what is known as open partial laryngectomy. Open partial laryngectomy. It is known as OPL. Yes. T4, if it's a late stage, then nothing can be done. You have to go for total laryngectomy plus you have to go for total laryngectomy here. Right? In T3, T4. Now, what is open partial laryngectomy? Okay, now open partial laryngectomy, just see here, if it is a recurrence following radiotherapy and the tumor is T1 or T2 of the supraglottis or only of this area, only limited to supraglottis, right? Then what we do is in partial laryngectomy is we remove the part of this complete above the true vocal cord, this complete area, this we remove. This is what is known as horizontal laryngectomy. Is that clear? So open partial laryngectomy can be either horizontal. Horizontal is also known as supraglottic laryngectomy. Yes. So if you are doing supraglottic laryngectomy, you are doing it for which carcinomas? Yes, for supraglottic carcinomas. You are removing the supraglottis for supraglottic carcinomas. Supraglottic carcinomas. Is that clear? So if it is a supraglottic carcinoma, then we can go for early stage, we can go for a supraglottic laryngectomy. That is also known as horizontal laryngectomy. Now if it is a glottic carcinoma, recurrence following radiotherapy, glottic of the true vocal cord. Okay, true vocal cord. Now here what we can do is we can go for a vertical laryngectomy. What is vertical laryngectomy? Vertical laryngectomy is you remove one part. Here we have the true vocal cord, right? So what you remove is you remove one half of you split the larynx vertically. You remove only that particular part of the true vocal cord, this much, and a little part above that will include the false vocal cord and a little part below this true vocal cord. Okay, so one half complete. You split the larynx vertically and remove that. That is what is known as vertical laryngectomy. So, which means that in vertical laryngectomy, what we are doing is one half of the thyroid cartilage, one half of the one half means one half, either right or left. Yes, one half of the thyroid cartilage, one half of the false vocal cord, the true vocal cord and some part below it. So true vocal cord along with some part above it and below it, this part we remove, right? This is what is known as vertical laryngectomy. So open partial laryngectomy can be horizontal or it can be vertical. Vertical is known as hemilaryngectomy also. Hemilaryngectomy. This we will do for glottic carcinoma. Glottic carcinoma. Early stage, yes, T1 or T2. This is also for T1 or T2. T1 or T2. Now, was this question asked in your exam? Patient of carcinoma of the larynx involving the right false vocal cord, epiglottis, left false vocal cord with bilateral mobile vocal cord, post radiotherapy. Post radiotherapy. Yes, what will you answer? Or yes, you can go for a partial laryngectomy. Which one will you go for? Right false vocal cord, left false vocal cord and epiglottis also. and bilateral mobile vocal cord. Vocal cord is normal, means all the tumor is in the supraglottis. The true vocal cord is not involved here. Then you will go for a horizontal or a supraglottic laryngectomy. Is that clear? Okay, that is clear now. Now there is another tumor of the larynx which is a variant of squamous cell carcinoma. That is what is known as verrucous carcinoma, or it is known as Ackermann's tumor. So all that you need to know in this tumor is that it is a variant of squamous cell carcinoma. And is it a good variant or bad variant? Yes, it is locally invasive. It does not metastasize, no metastasis, and it is very slow growing. So it is a good variant, yes, slow growing. And here we always want to preserve the larynx. So how do we manage this? Management is either by TLM, or what we can go for is radiotherapy. If it's extensive tumor, then we can go for radiotherapy. So these are some points that we need to know. And yes, you must have heard this tumor in other places also. Yes, this can be seen any other place also, oral cavity also it can be seen, and this appears like whitish growth. So if any growth like this is given to you, you know that this is a variant of squamous cell carcinoma. Yes, this is the oral cavity that we are seeing here. So this is a variant of squamous cell carcinoma known as Ackermann's tumor or verrucous carcinoma. So now we have completely managed this patient who came to us with hoarseness of the voice. And we examined the neck, we took a biopsy, we confirmed. Which investigation did you do to confirm a cartilage invasion? Cartilage invasion. Yes, you went for an MRI, and if the MRI showed the cartilage invasion, which stage would it be? If there is extensive invasion of the thyroid cartilage, extensive invasion of the cricoid cartilage, if there is extensive cartilage invasion, then it becomes a T4 stage. And in cartilage invasion, do you go for radiotherapy? Yes or no? Will your management change? Yes, you will go for total laryngectomy. The important other thing that you need to see is the mobility of the vocal cord while examining the patient. If the vocal cords are fixed, immediately do you know that the management will be? It is at least a T3 stage. It is at least a T3. So you will go for concurrent chemoradiation. If it has not gone out of the larynx, if it has gone out of the larynx into the strap muscles, into the thyroid cartilage, if it has gone outside, then you will go for total laryngectomy followed by radiotherapy. But if it has gone to the prevertebral space, if it has gone to the mediastinum, then only palliative management. Small lesion on one side of the vocal cord, only on one vocal cord. What will you do? Yes, that is which stage? T1A. Then you will go for just excision by TLM. Which laser do you use here? Yes, the carbon dioxide laser. So is it absolutely clear? The management of carcinoma of the larynx. Have you understood that? Okay, so now you have removed the larynx of the patient. You removed the larynx of the patient. You did a total laryngectomy. Now, how will this patient breathe? How will this patient breathe? You have removed the larynx. Larynx has such an important function of respiration. How will this patient breathe? Yes, so what you do is, after you have removed the larynx, what is left behind is the trachea below. You pull out that trachea and you suture it to the skin outside. So what you do is you make a permanent tracheostome. Yes, so what is a permanent tracheostome? What is the difference between tracheostomy and tracheostome? Again, that has been asked in your exam. Tracheostomy is making an opening on the interior wall of the trachea, whereas a tracheostome is when you have pulled out the trachea and sutured it to the skin outside. So permanent tracheostome is suturing the trachea to the skin. The trachea to the skin, and the patient will now breathe through this. The patient who was earlier breathing through the nose, and the air was going through the nasopharynx, the oropharynx, and then into the larynx. Now he is breathing directly from this permanent tracheostome. Okay, at least he is able to breathe, right? How will he speak? Earlier, how he was speaking, the subglottic air pressure was coming from below. The vocal cords were adducting. Subglottic air pressure was building up, and it was, when it crossed a particular level, it was being released, vibrating the vocal cord. Yes, this was turned into speech by our articulators of the mouth, of the pharynx. Now we do not have the vocal cords. Yes, and the subglottic air, everything is from here. We do not have any vocal cords. So now how will this patient speak? Yes, so for speaking of the patient, which means that this is something which is very, very important, because the speech is so important for us to communicate, for us to do everything. If we are not able to speak, what will we do here? Yes. So the rehabilitation of speech following laryngectomy is a very important topic, repeatedly asked. Yes. So what were the modes of rehabilitation of speech following laryngectomy? Yes, the earliest was the esophageal speech. The esophageal speech was that the patient was made to learn to swallow air before he spoke. So not only that much, he will swallow the air, and now he will regurgitate the air. He will regurgitate the air to vibrate the hypopharyngeal segment that was behind the larynx. Behind the larynx, we have the hypopharynx. We have removed the larynx. What is left is the pharynx, the hypopharynx. So he will use that regurgitated air to vibrate the hypopharyngeal segment, and that vibrations that are produced, now he uses that to produce speech. That is what is known as esophageal speech. That was a very, very difficult form of speech to develop, and patient could just swallow air, speak 2-3 words, and then again swallow air, again speaks 2-3 words. And not only that, it used to take months to learn. Maybe most of the patients never were able to learn it. So that was what is known as esophageal speech. Now, nowadays, what we have developed is the best form of speech following laryngectomy. That is what is known as the tracheoesophageal speech. This is the second form of speech, tracheoesophageal speech. This is the best. This is the best form of speech following laryngectomy. Here what is done is, just see here, a valve is attached. This is a valve, okay? A valve is attached in between. This is the trachea. This is the trachea that you have pulled out and sutured to the skin outside. Now behind this we have the pharynx. The food is going here. It used to come to the larynx. The air used to come to the larynx, and the food goes from the oral cavity to the hypopharynx, right? The larynx we have removed. So now the trachea, in between the trachea and the pharynx behind, right? So in between the trachea and the pharynx behind, what we do is we put a valve there. This is a one-way valve through which air can go into the pharynx, but the food from the pharynx cannot come into the trachea. This is a one-way valve. Now what will happen here is, what we need actually is we need air to vibrate the pharyngeal segment so that some voice can be produced because of vibration of the pharyngeal segment. So from where do we get the air? Here what we do is we have connected a valve in between the trachea and the pharynx. During expiration, whenever a patient wants to speak, during expiration, he will close this opening of the tracheostome. Now, all the air during expiration will get diverted through the valve to the pharynx. That air will vibrate the pharynx, and that will be used by the patient, those vibrations will be used by the patient to produce a speech. This is what is tracheoesophageal speech, and this is considered as the best form of speech. Why? Because the air that is coming is a lung powered air. So a lot of power of the air, a lot of vibration can be produced of the pharynx to produce a good voice. This is what is known as tracheoesophageal speech. And the valve that we put here appears something like this. So this one part is in the trachea, the other is inside, the one is outside in the trachea, and the other is inside, that is in the pharynx, toward the pharynx part. And when it is put, this is how it appears. This picture was given to you in your exam and asked that what is this mode of rehabilitation for speech, or what is this type of speech? Yes, what is this surgery? So this is the tracheoesophageal speech, and this prosthesis comes in the name of many names. The famous ones are the Blomsinger and the Pange valve prosthesis. And again, this picture has been given to you in your exam and has been asked that what is the mode of speech that this patient is using. So yes, you have to notice whenever this is given to you, just try to see whether you are able to see some small valve or not. Don't write this as esophageal speech. Yes, this is a tracheoesophageal. The valve has been put there. See that properly. That is the only thing that you need to see if a picture like this is given to you. Now, whenever this patient wants to speak, what he will do is, during expiration, he will put a finger here and he will speak. He will use this air to be diverted, the expired air not to come out but to get diverted to the pharynx, and he will use this air to speak. Now, this was a problem because if he is doing something, some work. Both his hands are involved. So then, if he wants to speak, he will have to close the tracheostome opening with one finger. So nowadays, there is a button which can be used, a button which can be closed here, and that automatically does the function of the finger, and that is what is known as a hands-free tracheoesophageal speech. So the valve that is put inside is the same that we put inside. The only difference in hands-free is that the function of your finger is being done with a button there. Now let us quickly see a hands-free tracheoesophageal speech. In this patient, post-laryngectomy, the tracheoesophageal puncture was done and the tracheoesophageal valve was placed. But yes, he was disturbed because of the hand being used every time he had to speak. So the hands-free was put, and just see how his voice is.
It was the most important moment that Dr. Selby treated hands-free, and I am able to speak without putting my finger over my stomach.
Now sometimes granulations form at this valve area and this valve closes, or it repeatedly gets infected and it needs to be removed. Then in that case, what option can be given for speech to the patient is something which is known as electrolarynx. Yes, so that is what is known as electrolarynx. This is the third form of speech following rehabilitation of speech that we can give for post-laryngectomy patients. Electrolarynx. Electrolarynx. Now what is this? This is a device where he places this electronic device which just produces vibrations. So it is placed against the neck and it produces vibrations, and those vibrations are used to produce speech by the patient. This produces a very monotonous robotic voice. How the robots speak, that is the type of voice these patients have, robotic voice. So this is how he will place it, and he will speak whenever he has to speak. And now let us quickly see how the voice is when the patient uses an electrolarynx. Now in this patient, the patient had a TEP, a tracheoesophageal prosthesis earlier, and which failed, and because of which he is now using a electrolarynx.
पहले मेरे टीवी लगी हुई थी, 2-3 साल तक लगी रही मेरे, उसमें प्रॉब्लम होने की वजह से मैं अब ये मशीन यूज़ कर रहा हूँ. अब इस मशीन से मुझे कोई भी प्रॉब्लम नहीं है, मैं अपना बिजनेस कर रहा हूँ.
So what we saw is that post-laryngectomy, when we have removed the larynx, we have taken care of the speech quite in a good manner. Patient is at least able to speak and communicate, right? Now what can be the other problems that can occur following laryngectomy? Now when we are breathing through the nose or when we are breathing through this tracheostome, will it make a difference? Yes, we know that nose has a very important function of temperature regulation, of humidification, which means that if the patient is breathing through here, this function of the temperature regulation and humidification of air is not being taken care of. So the patient has he has drying or dry air which is going inside, he has repeated crusting of the airway, he has repeated cough, repeated infections. So for that, can something be done? Yes. So to filter the air and to humidify the air, we can use a prosthesis which appears like this. This is what is known as a heat and moisture exchanger. So this takes care of humidification and filtering of air. Humidification plus filtering. Now also, if the patient is not breathing through the nose, does the nose have another very important function of smell, of olfaction? Yes, so if the patient is not breathing through the nose, patient is breathing through here, will this patient be able to smell? Will there be loss of taste and loss of smell in this patient? Yes or no? Yes, we know that the taste, the flavor of the food also comes from the smell. So yes, that is also a problem following laryngectomy. So can that be taken care of? Yes, that can also be taken care of. So when we want to give olfactory rehabilitation, rehabilitation, this can be done by a procedure which is known as polite yawning, and this was a question last year in exam. Olfactory rehabilitation is by polite yawning. Polite yawning. What is polite yawning? Polite yawning is, how do you yawn? You can yawn with your mouth open, or yes, you can yawn with your mouth closed. So what is polite? Yes, when you're yawning with your mouth closed. So what happens? Just try to do that and see. When you're yawning with your mouth closed, what happens is like that. Yes, so you create a negative pressure in your mouth. Do that and see. Yes, so when you create a negative pressure in your mouth, that induces air from the lungs to come out. Just do that and see. You will see that when you do this, you ultimately what you do is you do expiration, and that air goes through your nose out. So whenever you are doing polite yawning, that creates a negative pressure in the oral cavity that induces expiration, airflow through the nose. So when the air now goes through the nose, it reaches the olfactory mucosa and the patient can get some sense of smell. So that is what is known as polite yawning. Yes, you just need to know this word, and you can just try this and you can see how it is inducing nasal airflow. So this is induces nasal airflow. Nasal airflow, and the patient can smell. So yes, we can take care of the speech. Following laryngectomy, we can take care of the breathing. We have made a permanent tracheostome. So the patient is breathing through here. We can also take care of the drying and the filtering of the air, the humidification of the air, that is by a HME humidifier, a moisture and a humidity exchanger. We can also take care of the olfaction part. But what we cannot take care is of the chest fixation. We know that larynx has important function of when the vocal cords adduct in midline, the subglottic air pressure, the intrathoracic pressure builds up, and that stabilizes the chest, and that helps you to lift heavy weights, and that also increasing the intrathoracic pressure helps in coughing. So the cough part and the lifting heavy weights, that still cannot be taken care of. So there is still inability to lift heavy weights, and inability to cough. So this is what still remains. So patient post laryngectomy, if was a laborer, will not be able to continue with that profession. If was a weightlifter, cannot continue with that profession. Yes, so that is what we need to know in carcinoma of the larynx from A to Z. Yes, that is what you need to know, everything about carcinoma of the larynx. So which is the most common carcinoma of the larynx? Glottic carcinoma. Which is the carcinoma with least lymphatic metastasis? Glottic. With maximum lymphatic metastasis? Supraglottic. With the earliest presentation? Again glottic. If there is neck nodes which you want to remove along with laryngectomy in a neck dissection, which neck nodes do you remove in a patient of supraglottic carcinoma where the nodes are not yet there? Which selective neck dissection will you go for? Which lymph nodes will you selectively remove? Which group? Yes, the lateral group. What is the lateral group? 2, 3, 4. And which group? And Delphian. What is Delphian? Delphian is anterior. Supraglottis drains into which lymph nodes? 2 and 3. Subglottis drains into which lymph nodes? 4. Which is the site of the larynx with the least lymphatic metastasis, with best prognosis, with earliest presentation? Yes, that is the glottic carcinoma. If the glottic tumor is localized to one part of the vocal cord, right vocal cord, only in the mid cord, what is that stage? T1A. How will you manage that stage? How will you manage that tumor? Yes, that is by TLM. If there is a glottic carcinoma of both the vocal cords with bilateral mobile vocal cord, both the vocal cords bilateral mobile vocal cord, management. Yes, either it is a T1 or T2. So it is a TLM or radiotherapy, anything you can go for. With bilateral fixed vocal cord or any one fixed vocal cord. Now management is concurrent chemoradiation with involvement of the thyroid cartilage. Now it is total laryngectomy followed by radiotherapy. Following laryngectomy, what is the rehabilitation? How do you give rehabilitation of speech? Speech is by 3 types of speech. Yes, rehabilitation. Esophageal, electrolarynx, and the voice prosthesis. What is that? Yes, tracheoesophageal voice prosthesis, tracheoesophageal prosthesis. What is the best out of these? Yes, tracheoesophageal prosthesis. That is the best. How do you give rehabilitation of olfaction? By polite yawning. How is the voice in electrolarynx? Yes, the typical, monotonous and robotic voice. Okay. So quickly do your questions.